Welcome back. We'd now like to hand the program over to Keizo Takemi and Tim Evans. Thank you.
Thank you very much. We would like to start this session inviting the very distinguished guests, the ministers of the countries, the purpose of this session is that how the leader of the health policy making in each country recognize the meaning of the universal health coverage. And secondly, we have already requested the panelists how you can utilize the outcome of our joint research, World Bank and Japan, for the universal health coverage. Therefore, I do hope that we can talk how we can achieve the universal health coverage in what context, and then how we can create the new and flexible approach for the universal health coverage through the outcome of the joint research program. And I would like the Tim Evans to take the floor for the coordination of these sessions. Please, Tim.
Thank you very much, Professor Takemi. So welcome to our panelists, and we're delighted to have 5 ministers on this panel, and Professor Takemi has prepared them all with probing questions with respect to what universal health coverage means in the context of their respective country contexts, and how they think they might be able to use some of what has emerged from the case studies in this being looked at in this meeting in their own contexts. So I'm going to invite each of the ministers to begin by giving us a couple of introductory remarks to reflect on those questions. And once we've heard from each of the ministers, I think then what we'll do is try and get this session interactive and get questions from the floor, which allows some of you who have been involved in the case studies, but also involved in the discussions yesterday, to look at how, in the context of real policymakers, we can see how some of these, how some of the evidence and the interest in UHC might get translated in specific contexts. So I'm going to begin with Dr. Kebede Worku, who's the State Minister of Health in Ethiopia. Dr. Worku, we're just wondering your views on UHC in your country and how this meeting might help move things forward.
Thank you very much. I will start with the 1995 Constitution, which has some important articles that puts health as a national, the right to equal access to publicly funded social services, and also government to assign and allocate increasing budgets for social services like health and education. Saying this, in our context, when we say universal health access, we are talking primarily about universal primary health care services. And we have reasons for that, and I will explain it later. And as a country, we have a sector-wide approach and planning, and we have overarching national development plan, in which health sector development program is one of them. We have aligned our priorities to address our major health problems. Most of our health problems are unlike the ones in developed nations. Our communities are suffering from communicable diseases, which can be easily preventable and or treatable. So we are addressing our focus in this line. And so we are building strong primary healthcare services. And we are building in a way that can physically as well as financially be accessible to citizens. And our government in general has a proper budget allocation and expenditures, and primarily focusing on health, education, agriculture, water, urban, particularly housing, and also addressing environment and gender in such a way. So, the government is also highly committed in addressing the social services, and we cannot grasp all things at a time, so we need to prioritize, and the stage-by-stage actions are also necessary. And I need to share to you the flagship program that we are implementing, the health extension program, which is a base for our primary health care. And I don't need to repeat what has been said so far. We are able to attain the MDG4 3 years prior to the set deadline, and we are also committed to address and meet the other MDGs. Political commitment and community ownership and participation. Particularly, we are working at grassroots levels, coordinated efforts, or at village levels, and organized community movement, which we call Health Development Army. And we are working in a fashion that can transfer knowledge and skill to householders, particularly women, who can also serve the respective family at the same time. That will sum up to be bringing a healthy community and healthy village in general. So we enjoy also partnership at a national level with local and as well as international partners. And in the health extension program, the services are provided in an integrated manner. And all health extension workers, which are close to 38,000, are on government payroll, and this demonstrates the commitment as well as ensures the sustainability of the programs. And it is not something that depends on projects. Rather, it is part of the frontline health delivery mechanism in our country. And we are linking the health extension program with our health centers, which are a first referral for the health communities that are getting services at health posts and by the health extension workers. And of course, we need to work to improve the quality of care, and we are upgrading their level of training from level 3 to level 4. Level 3 is a sort of college certificate. Level 4 is a college diploma equivalent to nursing. And we have already started scaling up the level of training. And I need to come to the second one about the universal health coverage, which we have heard of from different countries, including the synthesis report by the World Bank and in consultation with jointly with the Japanese government. And we have learned it is not an easy task. It is a very difficult task, and it will take time. So we will consider it as a process, and but considering it as a difficult, demanding task, time-taking process, we need to start. Without starting, we cannot finish. So we need to start that, and we are at a different stage of development, and we might face challenges, our act was passed in 2010, in July. We have started learning about the health insurance since 2006, 2007, and still we are learning, having a knowledge from different parts of the world, from different institutions. It might not be implemented easily, so it needs country context, and at the same time we need support from global communities, particularly into building our implementation capacities. So these are where we need support from donor communities and the bilateral governments who have been supporting us. So we need to start, at the same time evaluate and define our schemes that is to be implemented. Of course, we are not to start only the formal or public servants scheme. We have already started implementing the piloting of the community-based health insurance since 2 years, and we are to expand that to first phase of implementation in 161 districts, based on the experience that we have got from the 13 districts of implementation. And for formal sector, we will start from the public servants, because we need to learn what challenges we will face. So from January to June or a year, we will start implementing for public servants, and later on including all private and other formal employees to be in the scheme. So it's a learning system, and we need to address the expectations of the public, particularly in providing quality services. We may take their money in as a scheme, but if you don't provide them the services that they are expecting, or to the level of the health service care, we may fail, and that will backfire and drain the system.
Great.
Okay.
Super. Thank you very much. I think we've got a very good picture of your efforts to really extend services to the entire population, and then these financing reforms that are coming forward. And I think this is going to provide some great opportunities for questions. We'll move now to the Honourable Minister from Ghana, Mrs. Sherry Ayiti. And we're wondering, Honourable Minister, if you can give us a sense of where things are and what you think you could take away from this meeting.
Thank you. Thank you very much. From where we have come from, our insurance scheme started 10 years ago. We are barely 10 years ago. And it's a mixture of tax-funded, program with Social Security and other funds from statutory, financial sources. I think we have actually been able to have a strong political commitment to our insurance scheme, and this is very important because, in Africa we have such a, porous political landscape, but successive changes in political government, actually has not undermined the insurance scheme. With the insurance scheme in Ghana, we have been able to register strong gender and children coverage. We provide free maternal and child care, and also we have included the vulnerable groups in our insurance scheme, especially patients with mental, sickness. We have also realized that we need to overcome our technical capacity for the implementation, and also we must have continuous stakeholder engagement in the insurance scheme. If having listened to the presentation from the World Bank, I mean, what is more focused in my mind is that it's important that we should have country ownership of our program because of varied cultural backgrounds and political ideology. So it is very, very important that the country must develop its own path and also own the scheme. There's also one thing that I realized looking at Japan. Japan started in 1920 when the economic landscape was different to 2011. I mean, they've traveled a long path. But for us, emerging economies, we find ourselves in a position where we must have the political will to overcome the financial struggles that we need to, face if we have to have a successful universal health coverage. Universal health coverage for me from the, program by the World Bank, strengthens the idea that it's a long process and we need to work towards it. We need to have a strong commitment towards it. And I think that one thing that is also emerging for me is that it's important that we should also regulate the fees that our private providers charge, and also to have a better supply chain when it comes to drug supply, because it is something that we need to look at, and then also strengthen the ongoing hospital reforms that currently Ghana is undertaking, because that will provide a better environment for better quality health delivery system in Ghana. And I think the idea that we need to have a better dialogue with our ministers of finance is welcomed, because we have budget ceilings, with the world economy, and with financial distress all around. It is important that we should dialogue with our ministers of finance so that we can look at how governments can actually sustain their financial commitment to rolling out the universal health coverage. And I will welcome that the World Bank will be able to work out, a dialogue or a meeting for ministers of health and ministers of finance to understand that health is not a commodity. Health is a human right issue, a development issue. And you can only measure the success of your economic program when you have a healthy people. So this kind of dialogue should bring ministers of health together so that whilst we look at economic, getting economic recovery on the agenda and generating profit for our economies, we also need to realize that it is important to look at the health aspect of our people. Thank you so much.
Thank you very much for your comments. We're going to move now to the Honorable Minister of Health from Myanmar, Dr. Batkin. What are your views in terms of where you are with respect to UHC and how this meeting might help?
Thank you, Tim. First of all, I would like to thank the organizers, Government of Japan and World Bank to invite Myanmar to participate in this important conference. As you know, Myanmar is in a very early stage of the process to achieve UHC as part of its Vision 2030 for a healthier and more productive population. We believe that UHC would help achieve the twin goals of our health sector, that is, improve health outcomes and reduce the financial burden on the poor and the vulnerable due to health expenditures. More importantly, as you know, our political landscape over the past 60 years since we got independence from British, UHC would contribute not only towards the socio-economic development of the entire people, that is the Agenda 2 of our government, but also contributes to the national stability, ethnic reconciliation, and solidarity of all national races through equity issues. That is, of course, our national agenda number 1. The Ministry of Health has conducted 4 consultations so far on UHC, and part of the ongoing socio-political transformation, we have significant reforms on the health sector as well. Between 2001 and 2011, Myanmar was able to reduce infant mortality, maternal mortality, so on and so forth. But we have to acknowledge that there is a considerable room for improvement in health outcomes from Myanmar to compare favorably with other countries of Southeast Asia region. Moreover, the Ministry of Health is conscious of the potentially catastrophic and impoverishing effect of high out-of-pocket expenditures. It's 65 to 80% depending on the different regions of the country, and serious implications for equity access to healthcare services. In an effort to address this issue, the government has increased its health spending 8-fold over the past 5 years, with large capital investment in health infrastructure and a free provision of essential medicines program, which accounts for the most of the increased spending. But still, both the total health expenditure and government health expenditures in Myanmar are among the lowest in Southeast Asia. We have already set the target of increasing health expenditures by 1% of GDP annually. Currently, it is 2.5% of GDP and 3.5% of total government expenditure. There are plans to extend social security benefits coverage to all government employees, establish social health protection schemes to vulnerable populations, and support from development partners, and provide priority to vulnerable populations with support from development partners. One advantage at this present times is previously we were not able to employ as much health workforce as we need because of budgetary constraints, as well as government ruling the ceiling is 2/3 of the sanctioned force. We cannot employ more than 2/3 of the sanctioned force. But now we have the budget, and the restriction was lifted. But suddenly we find ourselves in shortage of healthcare workers rather than surplus. Previously, we thought it was surplus because we were not able to employ that we were producing from the universities and schools. We have more than 64,000 villages. So even though we can employ what we have already produced, there's a large gap. So we still have to rely on the volunteers. And we need to increase the training capacity. So not only from the public sector, but now we recruit the private sector to take part in human resource development also. So we are trying other options, both to increase the resources available to the health sector and to improve the efficiency, effectiveness, and equity of the health services. Lessons we have learned, it is the huge need for strong political will and commitment. The current government's commitment to putting Myanmar on the path to UHC is very strong, and we recognize that UHC can be achieved only by sufficient and sustainable attention being paid to all of its interlinked dimensions like population coverage, service coverage, and financial coverage. And it is also very important to have short-term gains. As a career pediatrician, previously I did not really believe in quick wins and low-hanging fruit because, you know, health and education is a long-term process. But as part of the government, I need to produce some tangible short-term gains. And it is very important to have, like my colleague told just a few minutes ago, that, you know, everybody is, you know, telling us what to do, but we need how to do it. We know what to do, but this is the how to do it in a more a practical way is more important, in my opinion. And whatever we do, although we have public finances, we know that government financing alone will not be enough to cover all these issues. And the other thing is health system strengthening. It is very important for us. It's a cross-cutting, diagonal approach that without a good and strong health system, we will never be able to deliver what we aim to deliver. So right now, just now, we have had so many things. I'll try to remember and note down and bring home what we have discussed over the past yesterday and today. Institutional arrangements and governance mechanisms. It is very important, and the need for cross-subsidy, but we have to discuss with the colleagues and friends from the Ministry of Finance also, and compulsory contributions. Whether compulsory is the correct word, I'm not sure, but we still have to discuss. And pooling, risk pooling and sharing, not only pooling, but sharing is also very important, I think. I shall take these lessons back to Myanmar and share with officials from my ministry as well as aligned ministries also. And I'm very glad that we are going to send a team to flagship training on health sector financing and universal health coverage next week here in Tokyo. Thank you very much.
Great. Thank you very much again for a very lucid account of where you are and also some of the lessons that you're drawing. We're going to turn now to the Honorable Minister of Health from Senegal, Dr. Awa Kolsek, and if you can give us your own reflections on these two issues, please.
Thank you. First of all, I would like just to remind everybody that Senegal is a low-income country, known, I think, because of the soccer team, but also because of democracy. But we would like to be known also because of the effort we are doing on trying really to improve the work on health, and particularly by engaging our work on universal health coverage. I would like just to give also some idea of where we are concerning our indicators very quickly, to say that we have done a lot of progress when we look at some MDGs, particularly MDG 6, tuberculosis, HIV/AIDS, and malaria, but also for reducing child mortality. But we have very bad record when we look at maternal mortality. We have another problem now, is that we have some non-communicable diseases as really part of our day-to-day agenda. So it's a very broad challenges, and we would like now to engage on universal health coverage. What is the situation? We need just also to say that less than 2 years ago, we had a change on our country, and we came with this idea, led by the President Macky Sall, that we would like to have now a very strong universal coverage. And we were at 20% of the population having health insurance, 20%. We had now to look at the 80% remaining, and these were from the rural area and also the informal sector. All the civil servants and people working on the formal private sector had their health insurance. And if I heard the professor just before, one of the big mistakes is to start by that. We did it. Now what we want is to reach the others. And this is a big challenge, but we are ready to really try to overcome it. It is why we also have one very important asset, which is this political commitment my sister was also saying and the others. Without that, I think that all our countries will be in a very difficult situation. And what we have in Senegal is the head of state himself being the main advocate of universal health coverage. And this has helped us a lot. I have no problem with my Minister of Finance. I have no problem with anybody because they know that this is a high priority for the country. And the President himself has been involved in the issue of financing and sustainable financing, asking for budget ceiling and ensuring that in the budget we will have always money for universal health coverage, but also looking at innovating financing mechanisms and discussing with the local government to ensure that municipalities also are involved. One other thing is the strategy we have now and launched by himself was just to show that this political commitment has helped the Ministry of Health really to go very quickly, I think, and we would like now to implement what we have now decided to do. One thing I would like to share with you, because it's a little bit controversial, is that we are really promoting voluntary health insurance. On our plan is not the mandatory health insurance we are seeing in a lot of countries. Because those who are remaining are the rural area and, as I said, and the informal sector. These people who are often not paying any tax, they are just doing their job. They say they don't have money because agriculture, they are very poor, etc. And if you want also to tell them you have to pay for your insurance, they are not ready to do that. And because also of all the democracy we are promoting, we have to speak with people, to engage them, to convince them, and maybe if it is not working, we will go to a mandatory one. We cannot start by that. So this is something a lot of people are telling us, this is not working, it will not work. We have never seen a country with voluntary insurance succeeding, but this is what we have decided to do. And I want you also to know it, and maybe in the discussion to try to see what we can do. But this is the country policy today. We are also promoting in this universal health coverage free or subsidized services, under 5 free services for these children, but also for the women when they are going with this, I think in English is cesarean, I don't know how it is in... Huh? Cesarean section, no, it's not too far. And also for dialysis people who have more than 60 years old, etc., etc. So we have trying to also support vulnerable population and poor people. We have put in place also an equity fund, particularly for the poorest of the poor, and these are really where we are today. And this has started 1 year ago, and we are really going and working very hard because we would like some things to be visible already, and after also to continue on medium and long-term issues. This is where we are in Senegal. I just want to stop here to be direct to the point, but I would like to say also that what I have learned from here is that we have challenges at all stages. And it is not because you have challenges that you will say, I cannot do it. And I am already with a lot of ideas coming from other experiences, and I think that we are all learning by doing. And by doing that also, I think that this is a very important priority, and we can succeed. We need always to know that it is difficult, but being difficult is not impossible. And this is what I learned from the time I have been with you. Thank you.
Great. Thank you very much. Again, clear set of clear sense of your context, but also you've turned the table a little bit by asking some very clear questions, and we're going to expect some answers to those from the audience when we turn to them in a few minutes. But before we do, we have Dr. Kim Tien, who's the Minister of Health from Vietnam, who's going to give us her reflections on where Vietnam is in UHC and some of the lessons that you're taking from this meeting.
Thank you. As a discussion yesterday, Vietnam has been starting the health insurance since 1990. So Vietnam have not much experience. So I would like to share with you something, as you mentioned. What's the achievement that we got? And the second, what's the challenges in Vietnam? And the third, what's about the resolution we could apply after learning experience from Japan, from other countries in Vietnam in near future, now and near future. And the first, I would like to talk something about the achievement we consider as achievement. The first, as you know, or as already discussed, Vietnam has formally adopted UHC as part of the National Assembly adoption of the law on the National Social Health Insurance in 2008. And in last year, the Vietnam Prime Minister adopted our proposal strategy to expand coverage to at least 80% of the population by 2020. And last year also, our Communist Party issued the resolution, the decision for the UHC in Vietnam. And also, we have a high political commitment that the health insurance coverage must be one important indicator yearly, every year for the economic and social development achievement of all the provinces and also authority in Vietnam. And by the end of last year, nearly about 68% of population was covered by the national health insurance system. In the early 1990, coverage was less than 1/3 of the population. And the second thing that we consider as the achievement, that in the early we focus and make priority for the group of the poor people, of the vulnerable group, like children under the age of 6, ethnic minority in difficulty commune, people older than the age of the 80, who are enrolled in social insurance with the full state support, 100 support from the government. And that's why improve equity and finance protection is important goal. Then already in the 5 years since we law introduced, we are see that catastrophic expenditure are falling, particularly among the poor And recently, the government decided, last year decided to support with premium with 70% for the poor people. And the third achievement we consider that we had a rather good the health system, and from the central level to the commune and village level. Almost commune health center, we had a medical doctor, and with other health staff, we take care of the primary health care and also the carry out the health insurance service at the commune health center. So it may be the good chance for the people to access the health service in the lower level. And the last, for the human resource, we make priority. We already submit, and the Prime Minister approved the planning and also the obligation of the rotation of the expert, qualified medical doctor expert from high level to go to the lower level to work for the 1 year at least. And also we carry out the pilot project to send the young, qualified and good medical doctor to the poorest 63rd district to carry out the job for 3 years for the men and 2 years for the woman. And before going to the lower level, they have they could get many priority and benefit from the municipality and from the government. But also, you know, we have many challenges. As you know, there are the first that the need to mobilize the tax revenue to really expand coverage. Vietnam subsidize 100% of premium for the poor and other vulnerable group, and has done since mid-2000. So Vietnam also subsidized 70% for the premium for those people we call near poor people, and also the 50% for the school-age children. So looking ahead to including the agriculture and informal sector using tax revenue to provide at least large subsidy will likely a big part of the statutory. And increasing the support from the government was never easy. But it has been possible, particularly given that Vietnam at high economic and government budget growth rates. So it's one challenge. So that's why up to now we have not yet applied the informal sector coverage. Informal sector coverage is still low together with adverse selection. And the second, that family enrollment has not been implemented. So we already had the change new law recently, last only 2 weeks. The Parliament approved our proposal to change the law in order to adapt it with the now new situation in Vietnam, and also to learn, also after learning the experience from outside, for example, from Japan, that we make the visiting in the early this year. That's about the family enrollment should be implemented as soon as possible. The second difficulty that we challenge you with is that the out-of-pocket money in Vietnam is still high. Now it's about 45%. And the second thought, that the benefit package is too generous as compared with small premium. And drug price is not well controlled. And quality of health service has not yet met requirement of the patient and population due to the public hospital overcrowding. Attitude of small group of the health staff is not so nice. They make the problem with the patient. They don't have smiling, they don't have the nice attitude, so it's a big problem for the population as well in Vietnam. And autonomy in public hospital with payment method mainly based on the fee for service result in abusing high technology and laboratory tests and using brand name medicine. So it may be make the bankrupt of the health insurance fund. And also we have some thing to make to reduce the inequity in the mountain area, especially in ethnic group, to assessing to the health service with high quality. And now what about the resolution that we want to do in the making in the new law approved by the parliament? We think that the first we should increase the coverage rate by enforcing enrollment of informal sector and enroll dependent of formal sector on family enrollment. The second thing that now urgent, that to improve the quality of health service in public care facility by some short-term resolution. We establish the satellite hospital equal like a provincial hospital in order to improve the capacity of provincial hospitals so that they can treat the patient by themselves. They don't need to refer the patient to the higher level in order to reduce the very overcrowding in big city hospital. And for the long-term planning, we design the family medicine and also we establish the big project to develop the primary health care system in community health center in population. The government already spent a lot of money for building the new and district hospital and near future for the community health center and applied health education. And the third, that they redesign the benefit package to control the price of the drugs and abuse the technology, etc. And we have not yet applied the method of the negotiation. We just apply the bidding, the price for the control the price of the pharmaceutical product, and we have not yet applied the method of the negotiation like in Japan. So we need the technical assistance from outside, from international organization. And also we just apply the fee for service and some apply payment like capitation. But for DRG, we just carry out some pilot, in some pilot. So we need the technical assistance from international organization and from other countries. So what about we learned from this meeting is we think that a good chance for us to learn experience from Japan. Japan is good example for to implement UHC since long term. That's why in the early this year, by myself and our delegation visited Japan nearly 1 week to learn many experience about how we apply in Vietnam. And from other countries, each country, they have their own experience. But how we can apply for each country, we can draw some general lesson, some general experience we could apply for all the country. But for some experience, we just apply for each country depending on the detail and reality situation of each country. And we hope in near future we could have a more forum and sharing experience to each other. Thank you.
Thank you very much. So again, great achievements, significant challenges, and new approaches to address those challenges on many fronts. Opportunities to learn. The floor is now open. We have some challenges that have been put out to those who have the solutions. So we'd like to hear what those are, but you may also have reflections on your own context, on some of the other studies, or some questions that you'd like to pose to the panelists. So I see a hand, and I see several hands, and so I'm going to try and get to those hands is the best way I can. I can't read the signs. I'm sorry, my eyes are not quite so strong. But we've got one at the table here at the end. Please, go ahead.
Thank you. My name is Carlos from Brazil, from the Institute of Applied Economic Research. It's more a reflection than to propose any kind of solution. On the contrary, regarding the Brazilian case, a Latin American country, as you know, still today, after the economical growth seen last decade, the poverty, the income inequality, even the social violence and the low level of education in our country impact the conditions of health population, and especially the capacity of the Brazilian government to provide universal health care for all, and keep in mind that formally we have universal health system since 1988, and also provoke some damage in the capacity of the Brazilian government to improve the quality of the public service. And for sure, this situation is critical in Brazil, which is a middle-income country. So, generally speaking, in my opinion, the requirements for achieving universal health coverage would demand huge shifts in the social conditions of our societies. But how to deal with this challenging situation in the short term? So, as I have been asking for myself this question, I would like to listen to you. Imagine that you can find some situation like we find in Brazil.
Great. Thank you very much for that reflection on your own context, but also the question to the larger audience, and other people may have reflections on that. I have on the left, on the back, with the sign still up, and then followed by Rob. Okay, there's a person on the left here who's ahead of you. Right there. Yep, please.
Yeah, thank
and
you very
just
much.
Introduce yourself, please.
Yes, I will. My name is Takumo Yamada, Advocacy Manager at Oxfam Japan. I'd like to know more about what the Honorable Ministers of Health are doing to encourage the Ministers of Finance in their countries to raise more government revenue for health, and what they think donors like Japan and World Bank can do to help their governments do that. The reason I ask these questions is that in our analysis, all the UHC success stories in developing countries rely heavily on general government revenues simply because of high poverty rate and informal sector. Therefore, in financing UHC, we need to explore how to mobilize more tax financing. Without this, the UHC efforts risk ending up providing healthcare on the principles of the ability to pay and not the needs. IMF research shows that the actual government revenue of low-income countries is only 78% of their fiscal potential and 63% in the case of lower middle-income countries. We estimate that improving tax collection in 52 developing countries could raise additional $269 billion. And in addition to raising more tax, we also need to make sure that the tax collection is done in a progressive manner, and we also need global cooperation to tackle tax dodging, because the multinational companies tax dodging collectively cost developing countries $160 billion, which is more than 4 times the amount spent on health by all countries in sub-Saharan Africa. There is an opportunity now on the tax dodging case at the OECD, the G20, and what have you, and also in the AU. I understand that there is a discussion on illicit financial flows. Good. So this discussion on universal health coverage should be proactively linked to those discussions going elsewhere on making sure countries can generate more tax in a progressive manner.
Great.
Thank you very much.
Thank you very much for that, again, interesting reflection and so those questions. We have at the back, Rob, please.
Thank you very much. If I could return to the excellent question that the Honourable Minister posed from Senegal before the break about a quick win for UHC, and you, of course, as politicians, are very keen to secure those wins. And ask you to maybe to reflect on an idea, a suggestion, which I hasten to add isn't my idea of a quick win for UHC, but actually it comes from perhaps the greatest political leader of the last century, who obviously sadly died today, President Mandela. And I'm not sure if people are aware that when he took over as president of South Africa with his dreadfully fragmented and unequal health system, the first thing he did was introduce universal free health care for pregnant women and children under 6 years old. Recognizing he couldn't do everything immediately, he went for that group first. Now, I know that some of the members of the panel are thinking about this or even implementing this as a policy in their countries. And we heard President Kim before talk about coverage of services. And two of the ones he mentioned were about women having safe deliveries and children being immunized. So this would fit with that idea of these being essential services. So would that be, do you think, a suitable quick win in your country?
Great. Okay, so we have a quick win question. I had, yes, please, at the end of the table here.
Hello, thank you. I'm Zomei Chang from Princeton University. Once again, also regarding the health minister from Senegal, you were saying almost, in a sense, apologetically that you are offering voluntary health insurance in your country. But I think that the voluntary insurance and mandatory health insurance, it is okay that in the stage of early insurance expansion to not put mandate on because of two reasons: that you may have the ability to pay issue with especially the poor and the rural populations. And second one is that the confidence in the government to do this, to deliver, is very much doubted by the public. So I'm thinking that, you know, there are things you can do to expand insurance expansion. Just picking up on what you just now said, that if you make health delivery, health services available through government subsidized health insurance. Here I'm thinking specifically about how China very rapidly expanded coverage of its rural health insurance. The insurance scheme a few years ago, before its 2009 major health reform, the rural population had only about 9 to 15% of the rural population covered. But very quickly, the government, through subsidizing the rural health insurance scheme, covered, as of 2011, something like 98% of the rural population, which is something like 830 million people. And what the government did really is to subsidize 80% of the insurance premium for the rural health insurance scheme.
Thank you.
Yeah, thank you.
Thank you very much. I have behind, is that Tomas? Yeah, please.
Thank you. I just wanted to point out purchasing that has been one of the health financing functions, and it's as a connecting point between finance and service delivery. And I think so far we have focused a lot more on the provider payment methods as purchasing. But I would like to underscore contracting as an important instrument for accountability, quality improvement, and engagement with private sector to alleviate some of the supply side constraints. And I've heard over the last 2 days mentioning made to the negotiations using soft power evidence as important institutional capability issues to actually engage better service delivery and achieve universal coverage. I think there's been under-discussed aspect of the purchasing function of health financing and service delivery. Thank you.
Great, thank you very much. I'm going to take the last 5 questions now. before we have to get back to our panelists. I have one here at the front. I have Professor Shao. I have here at UNFPA. We have right here, that's number 4. And out at the back, I think I could see someone who looks a little bit like me. All right, so those are the 5. I hope I haven't offended anyone by missing them or making other comments like the one I've just made.
Well, thank you very much. I'm called Samson Kironde from Uganda. And the question for my sub-Saharan African colleagues is HIV/AIDS. We all know that HIV/AIDS is basically the big elephant in the room as far as being a threat to universal health coverage because of the 35 or so million people out there who are living with HIV now. The majority of them stay in sub-Saharan Africa. And of these, I think we only have about 10 million of them on treatment, despite the fact that about 25 million or so need antiretroviral therapy. None of us, or we haven't had much during the last 2 days of deliberation, have talked about HIV/AIDS medication as part of universal health coverage. Yet we know that in terms of the revenues that we receive and the expenditures that we may have to spend on HIV/AIDS medicine, it has a very, very big potential of bankrupting any universal health coverage mechanism that we put in place. Right now, we are lucky that universal, global health initiatives like the Global Fund and PEPFAR are funding most of our HIV/AIDS programs in most of our countries. But what would happen in the long term if this basically ends? Because I think one day the GHIs are going to come to one end and we have to bear the burden ourselves. And if we are to have 35 million or so people on treatment for life, I think we have to think about these things and be able to see how they fit into the universal health coverage that we want to put for our countries.
Great.
Because HIV/AIDS is really one of the biggest problems that we have.
Thank you. Professor Shao?
I'd like to respond to the question, what are the low-hanging fruit? I don't think that we actually know what are the low-hanging fruit. But so I'd like to just repeat what we know. Namely, is emphasizing prevention and primary care delivered by health workers, not even by nurses. Look at what Ethiopia has done, what it's able to achieve. Look at what Rwanda was able to achieve. Look what South Africa was able to achieve with its HIV/AIDS reduction through health workers. Look historically what China achieved with barefoot doctors. Look at the India achieved in Kerala with health workers. Look at Sri Lanka. So I can name you, historically, we know the solution. What's puzzling is nations do not necessarily embrace that because they are not high technology solutions, as well as their physicians may actually oppose it and say, oh, these people are not so qualified. I think it's up to the leaders sitting on the podium to say, we know the solution, and we know what priority we should give, and then not rely even on nurses and physicians to deliver the health care, because that's proven. The complementary part you need is you need a good system, get essential drugs and vaccines to the villages and to the people. That, I think WHO and other organizations have developed bidding systems, supply systems. That was not in place 30 years ago, but now it is. So that's an obvious low-hanging fruit for low-income and lower middle-income countries, not for middle-income countries or high-income countries. Thank you.
Great. Thank you, Bill. I think there may be some people who challenge you on your last statement in terms of whether primary care is important for middle-income and high-income countries, especially given cost inflation. However, our next, yes, please.
Yes, hello. I'm Bruce Campbell from UNFPA. Bruce. I'd like to ask the panel a question in terms of quick wins, in relation to how you have utilized the data that you have available to you, and I'm talking about census data, population-based surveys, DHS, mix, civil registration systems, and of course, very importantly, routine health information systems, and the triangulation of those data sets to more effectively target your services and looking really at the low-hanging fruit or quick win of much, much greater efficiency by more effective targeting based on existing data sets that we have ready at hand, not already to talk about the new technologies and potential for innovation that we have, but just based on those 4 different types of data. Thanks.
Thank you very much, Bruce. And our final question or comment, please.
This is Kumakawa, NIPH Japan. So today in the conference, we learned a lot about the UHC, and we recognize the importance and difficulties, the finance, health delivery system, and human resources, and so on. And however, I heard, so now your presentation, especially Senegal, I'd like to ask you a question. To hear your presentation, I think UHC must be a kind of, social common capital. If you say so, if you think UHC is a kind of social common capital, community and citizens have to commit to UHC, I think. And a simple question, how to educate and motivate those citizens and communities for commitment to UHC. Thank you.
Thank you very much. And I was wrong. I thought it was the penultimate comment. We have a final one from Joe, please.
Thanks. I just wanted to come back to the discussion, in a way, responding to the comments from the minister from Senegal about, opting for or deciding that for now a voluntary approach for what might be called the non-poor informal sector was the only way to go. I think there's, in a sense, this is an issue that we need to probably take on and perhaps discuss further, because one thing that we can say is that the idea of unsubsidized contributions from the non-poor informal sector has really never worked anywhere, and I think that's the challenge. There are alternatives, and I think this is another issue. First, in terms of getting the question right. Okay, the question is not how do we get people into an insurance scheme, the question is how do we improve effective access and financial protection for people. So what are the priorities? And therefore, one alternative that some countries are doing has to do with what might be called, again, the results-based financing. So the linking service expansion funded from the budget, but really enabling that to happen with provider payment. And the other options that are more on the other part of financing is what might be called the tie approach, which is just using budget funds to cover everybody who's not in formal social security, or what we heard from Seng Mei about China's approach also in Rwanda, which is retaining contributions but bringing in a heavy element of subsidy from the budget. And those other 3 seem to be options that can work, whereas the first one, which unfortunately is something a lot of countries are choosing, is to go for unsubsidized contributions. That we know doesn't work, but it seems to have a very powerful hold on a lot of governments to continually try that.
Thank you very much, Joe. And on our way to the front, I had inadvertently missed Patricio. Please, if you could just give us your comment or question.
Thanks. Thanks. More than a question, I have a comment. I think that yesterday it was very clear, and also today it was very clear that universal health care coverage and related efforts have to be seen as an instrument to attain broader goals, broader health and social goals within a given society. That also implies that in pushing forward this effort to that we need to be careful in not falling into an over-medicalized approach. And as our colleague from Peru kept reiterating, the need to be mindful of pushing forward in parallel was part of this effort, health in all policies, in health in all sectors, in order to identify entry points to mobilize additional resources and efforts to improve the health conditions of the populations, all the way from taxation to road safety investments to water and sanitation, in order to really achieve the main objective. At the end of the day, we have to be mindful that health and good health is not only a biological phenomenon, but is a social phenomenon. Thanks.
Thank you very much. And I have the Director General WHO who has some comments for us. Please.
Thanks, Tim. I think thank you for the very interesting and exciting discussion. But I think the elephant in the room has not been addressed. And I agree with Professor Bill Shao. It's not that we don't have good examples of success and we know the solution. And many of you talk about the importance of primary health care, prevention, addressing the needs of women and children. It's the politics of things that make things so difficult. The vested interest groups. You talk about over-medicalization. Why do we get into that kind of problem? What about the doctors? Professor Takemi, you have done wonderful thing here in your country, but now you're moving into big challenge. Well, dare I say, the negotiation with the Doctors Association, and this is not unique to Japan. This is happening everywhere. So how can we find a solution that is what I say as a social contract of the government and its people, and all the vested interest group must play ball. There's no problem with making profit. Doctors should have a good income because they have gone through all this training. They are respected. But in some of the countries that I visited, when doctors turn themselves into money-making machine, and this is a challenge, when, over-medicalization, cesarean section is the norm now in so many countries. And then, all these high-tech, do we need them? So let's go back to basics. I want to thank you, Bill. I have not seen you for a long time. You are a staunch supporter of primary health care, and that's the way to go. Learn from Ethiopia, learn from Rwanda, Brazil, and there's no lack of examples. Why are we saying that we don't know the solutions? So the elephants in the room has to be addressed, and that has to be a global conversation, a national conversation, or subnational conversation. So the people of this world need to support their political leaders to get the right solution. Thank you.
Okay, so we have the challenge of a response from our panelists that is coinciding with people's blood sugar levels declining and the wonderfully prepared meal waiting. And so I'm going to ask each of you to give us a reflection, a further reflection, and to avoid the temptation of responding to everything, but to be very selective, realizing that over lunch you'll be able to discuss this a little further as well. So let me begin with the Honorable Minister from Ethiopia.
I need to give my comments on how we are working with the Ministry of Finance. Of course, there are different sectors, ministries, all do have their responsibilities into bring the nation to, at least for the medium term, to the middle level income country. So everyone is contributing, and we will not compete with other ministries, but we collaborate. We sit in the same cabinets, and we have also a constraint from the budget ceiling set by International Monetary Fund and other instruments. And we need to work to bring our economy in better place. Of course, we are also working aggressively in broadening our taxation system, and tax collection is getting improving, but that will also be financing other proper sectors. For HIV and other programs funded by the global community, we can incorporate in our health insurance scheme that we are developing, but we will not get rid of the assistance that we are getting from the generous global communities. We are thankful for what they have done, and we expect also contributions as based on the Paris Declaration of Harmonization and Partnership. So we appreciate that.
Great, thank you very much. Next, Honorable Minister from Ghana, your reflections.
Thank you very much. I think I'd like to respond that in Ghana, we give free treatment to HIV patients, and we take care of their medical bills. But at least I agree with the gentleman who spoke on the level of taxation and some of the reports from the IMF and the World Bank. At least there must be, I know that we cannot go on taxing the people. You know, the people are tax distressed to support the insurance scheme. We must find other innovative, financial resources to inject into the insurance schemes, and that will actually sustain the program. I also think that we must also look at contracting, and bringing in the private sector to support government commitments in providing universal health care for majority of the people. So we have to engage the private sector and civil society and non-governmental organization. It has to be a collaborative effect, approach. And I think this is something that we will consider doing. Thank you.
Thank you very much. Honorable Minister from Myanmar.
Thank you. So I'm diabetic, so I know the profound effects of hypoglycemia on a patient with diabetes. One thing, everybody is talking about the importance of finance minister, but in my country, it's a particular situation. Finance minister, there are so many people more powerful than finance minister, because every year we have to have a planned economy. So planning commission headed planning minister draws the plan, and the budget finance minister draws the budget. So both the commissions, finance commission and planning commission, has to put up a bill, law, to the parliament, and the parliament pass both laws. They can reject any single item. So parliamentary committees of budget committee and health promotion committee is much, much more powerful than the finance minister and the planning commission, planning minister. That's maybe our particular situation. That's one thing. Another thing is, I'm very happy that Professor Xiao and other people agrees with what we've been doing. But we started providing free medical care for under 5 children and free of charge delivery for women since last year. So the utilization rate was climbing very, very high and very, very fast, with resultant impacts on sterilization and sanitation. But maybe RHP, reproductive health people, may have some reservations about the women crowding to the hospitals for delivery. So delivery rate rather, I think it's increasing rather than decreasing, but it's good. Another thing is, we are trying to provide primary care. We know that the auxiliary midwives and CHWs are not recognized as skilled attendants, but we don't have much choice. We still have to rely on those people, because there are more than 64,000 villages. So we have already drawn up costed plans to train auxiliary midwives and CHWs, and I'm trying to urge the INGOs and all the development partners to contribute to that program. Because we've been training a lot of the CHWs and AMWs since 80s, but now we have so many INGOs coming into work for Myanmar, and they recruit our trained volunteers to their programs. So we are left with very deficient number of people. But I have to, my people, my staff are very much disappointed. But I have to tell them that although they are recruited by the INGOs, NGOs, but if they are still in the community and working for the people in the community, it's well and good. We'll train more. The only thing is we need more budget to train the volunteers. Another thing is the gentleman suggested census. Yes, our last census was done in 1983. We are going to have another one, the countrywide census in 2014. Then I think this will have a profound effect on the development of the future programs. Thank you.
Thank you very much. Honorable Minister from Senegal.
Thank you. Just one word on the issue of voluntary insurance. To say that it's an option, it's not something we are not ready to take on. We have started to do that. It's not a problem for us. It's just that often around it is another option which has been taken. But this is what we want to do, and we are doing it. The government is subsidizing by 50% also. It's just to show that we have a budget for that. And for some vulnerable population like the HIV/AIDS people, we have also, like in Ghana, free access to medication. But we know also that we have good record on this particular issue, and we know that the Global Fund will be focusing now more on high-burden countries. And we have to prepare ourselves, and it is why with the civil society, we are working to propose to the Parliament a tax on tobacco, which will be put aside for HIV-positive people, but also for the universal health coverage. So this is just to say that we need also to work ahead before we have some surprise. To educate people also, we are using all type of communication, using community radios, but also official radios, TV, theaters in the community, to explain to people what is universal health coverage and to push them to go and have an insurance. And more people are asking for that. And just to say that they are when they understand, they are well educated, they understand that their benefit is really to go and have an insurance, and also that the government will be supporting them. As I say, also the local government, the municipality are very involved in this work. I wanted just to finish by saying that having less people in the health centers and working on health determinants, these are options we need to put in the global universal health coverage, because it is not only insurance and also services, but it's also health promotion. And this is what we need to do to ensure that we will diminish the number of people going to the structure, and maybe people will use also the insurance. And this is, for me, something also very important we need to discuss more, because some are saying that, but often we are more focused on the financing, the money, the technology, but we need to avoid people to be sick. Thank you.
Thank you very much. And finally, our Minister of Health from Vietnam.
I would like to mention about the primary health care and prevention that Dr. Margaret Chen and others mentioned. It's not quite urgent necessary for the, like in the long term, but also in the short term, not only in developing low income and low middle income country, but as well as developed countries. But for the Vietnam, like low middle incomes, we make priority very high for the primary health care and prevention. In Vietnam, prevention is quite free for the whole population. But what about the primary health care in the lower level? We should make much more investment for the infrastructure, like the construction, the new or the favorable community health center, with enough medical devices for their primary health care and also for the health insurance clinical service there. And the most important about the human resource, the medical doctor, they don't want to work in the community health center. So now we have the special training for the medical doctor who works in community health center. It's one priority. If we have the community health, new building of the community health center, but without the good medical doctor and good medical staff, the people don't want to receive the primary health care, even they need. So we should spend, the government, for Vietnam, the government make priority for the primary health care at the lower level. The government have to spend money, not PPP or not the call the private investment. And the second thing about the health financing is always a big problem issue in the implementing UC. The first, we would like three components: the resource of the money, and the second thing of the beneficiary, the population, and the third for the providers, that the hospital. The government cannot supply more and more money for the poor people, near poor people, and for the vulnerable groups. And the other hand, for the Vietnam, like in middle income country, the structure of the economic with a large share of the population outside of the salary employment make it difficult to enforce their income taxes or payroll taxes in most citizens. It's not quite the same situation as Korea, Japan and Korea, because this country, they have a high income and they can encourage the contribution of the formal and informal sector. But for the Vietnam, so the resources from the population is limited. But the second issue, the constraint, the population, they want to get the big benefit package. Even now, in Vietnam, the premium is low, but they want to, we already had the good benefit package, including a cardiology intervention for the, also for the cancer. And now we want to implement the screening for the healthy people in the health insurance scheme. So it's impossible, and they complain, and it's very sensible for political issue. But they don't want to pay more money, but they want to get more benefits. That's the second issue. And the third about the providers, hospital. They want to make more money. If we have an autonomy mechanism for the public hospital, of course, we had some situation to abuse the medical doctor, abuse the high technology and brand pharmaceutical product and high technology in laboratory. So it spend a lot of money from the fund. And they said that's the quality of the service. They meet the requirement of the patient. So always three components always struck and fight together. So how we resolve this problem in order to make the finance balance and also meet the requirement of the people, and also to develop the public hospital provider, as you mentioned about the medical doctor, they should have a good salary. They should earn enough money for their life. But how we can control them also to meet the requirement of the patient?
Great.
Thank you very much. I'm looking at you, Professor Takami, if you'd like to have any concluding words.
Okay, thank you very much, the team. Wonderful coordination, and this is the very luxury time for us to talk about universal health coverage based on those of the panelists who is in charge for the real policy making, focusing on the health and the universal health coverage. And now we notice that always policymakers face a very serious difficulty and dilemma when they argue the importance of universal health coverage. Because it is very difficult to show the very concrete and symbolic evidence and outcome of the achieving universal health coverage at each level for the people. Without the people's support, policymakers cannot carry out own mission. Now, at least two conditions we have to think about. The first one, how we can increase the political momentum for the universal health coverage as the agenda, very important agenda for the national policy making at the country level and also at the global level. In order to do that, we have the tool. If we can successfully input this idea of universal health coverage as a key concept of the post-MDG discussions, maybe we can keep some sort of a political momentum as the common agenda beyond the national boundaries at the global level. And secondly, how we can show the evidence for the people of the achieving universal health coverage at each level. Measurement issues should be given a priority. And how we can we do realize that there are so many diversities for each people and each country to achieve the universal health coverage. Of course, we should respect the ownership of each country. But now, we have to courageously build up the consensus on which some sort of a unified measurement for the universal health coverage, and then show our people to what extent we can achieve the universal health coverage. This sort of the challenge we have to do. I hope that this wonderful session can contribute for the new step for achieving universal health coverage. Thank you very much for your wonderful contribution from the panelists, and your contribution is so great. And thank you for all of them here to contribute for the very fruitful discussions. Thank you very much.
Okay,
having a lunch.
Lunch, yes. Lunch is going to be shortened a bit. Please come back by 2 p.m. so that we can get back on schedule for today. Lunch will be in the Sunflower Room, same as the coffee break. And the first 15 minutes, I've been told to tell you that the Wi-Fi will be rebooting. So please enjoy your lunch, and then hopefully enjoy your internet after that. Thank you.